Hello, everybody. Welcome to our podcast today. We're going to be talking some about what we think may be coming in 2024, what we hope is coming in 2024 in the world of pain care. And I'd like to introduce our two guests tonight, Dr. Yoni Ashar and Dr. Ali Adler. But instead of me giving formal introductions, I'm going to have each of them just talk a little bit about their background. Maybe, Yoni, why don't you kick us off tonight?
Sure, yeah. Yoni Ashar, thanks for having me, Abigail. Great to be here. I'm now an assistant professor at the University of Colorado School of Medicine. I direct a research lab studying chronic pain in the mind and the brain. My background is I'm trained as a clinical psychologist and a neuroscientist. I've studied meditation and effects of meditation on the brain and how placebo effects work in the brain. And now my focus is really chronic pain and mind-body treatments for chronic pain.
Fabulous. And Yoni has been a long time from the beginning influence and clinical advisor to Lynn. And it's always such a treat for me at least, to get to talk to him. And Ali, will you introduce yourself?
My name is Dr. Alexandra Adler. I'm a pain physician and I'm an anesthesiologist. I'm an assistant professor at Tufts. But my primary job is actually as a pain medicine physician at a community private practice in Lowell called the Lowell Pain Management Center. I have a pretty long interest in chronic pain, but also sort of brain-body connection and harnessing that for treating chronic pain in addition to some of the other modalities we use.
Amazing. And actually, Ali, maybe you can share a little bit about how you and I got connected, because it's a lovely story. And I think at the heart of
So I actually found out about Lynn Health when it was more in an early phase through a patient who had found it on her own and used it for her own pain recovery. And she was a woman who had a really interesting history. She had a sinus surgery, and we know after sinus surgery, sometimes people have a lot of sensitivity to airflow. She was having a great deal of facial pain after her sinus surgery. But it wasn't just pain. She actually she had a lot of insight and was aware that she actually had a history of conversion disorder and a history of some other complex pain conditions. So she had suspected that there was something brain body going on there. And we managed her pain the way we typically do. We tried medications, we tried CBT, we tried different types of injections, and she got better and she got more confident as we went along. But she wasn't back to her job, which is a professor writing books. She found Lynn Health on her own. She did the program and called me one day and just said, I'm good. I'm fine. And she's back at work. She's writing books. She's published books. She's teaching. She's not a patient anymore because she doesn't need to be. And that's how I ended up reaching out to a couple of people I sort of peripherally knew who got me in touch with you, Abigail. It was all because of this patient and her really amazing experience with Lynn Health.
Yeah, and what's come out of that is a really wonderful partnership. And we can talk more about the details of it, but basically where the Lynn Health team is able to work under Dr. Adler's supervision in her clinic and bring this kind of care across many, many, many more patients to date. But so let me step back for a minute and let's just start by looking backwards a little bit and thinking about when we think about kind of the field of chronic pain care, what are things that we know today, if you were going to pick out something that really stands out that we know today that we didn't know, let's say 5 years ago. And then I'm also going to ask you a year ago, but let's start with 5 years ago. What would stand out for you guys?
I think there's two ideas that really stand out to me, and it's hard to put a particular date on them. Like this one,
Yes.
But one is actually exemplified by the story that Ali just shared, which is that recovery from chronic pain with a psychological behavioral treatment is possible. And that is a new idea. The traditional thinking has been that you can help people better manage their pain, help people live along with their pain more gracefully. But there's now, I think, compelling evidence, it's initial but compelling, that we can actually recover from chronic pain. And like that story you just shared this person is not a patient anymore. They're not, telling you, Dr. Adler, the facial pain doesn't bother me as much. I've learned how to live with it. They're saying, I don't have that. And that's a really remarkable and pretty new idea.
Yeah, I'll tell you when Ali, when you first came to me, what I recall about that story was you saying, I didn't even recognize that patient when she came back in my office. She was so transformed. And I think that, Yoni, all the more that we really didn't know that it's not just can we get the pain, we can get the pain to go away, we can get people's personalities back, we can get people's lives back. They can return to doing all the things they used to love. And I think I would add my favorite thing from the 5 years ago, maybe even 10 years ago, we didn't know that that is true in many cases, regardless of what you see on an MRI scan or or imaging findings. But what about for you, Ali? What on the year ago? What did we?
Yeah, so I think I think it's sort of putting the brain, the body, and the science and the chemistry together. And in the past year, we've learned a lot about chronic inflammation, the role of chronic inflammation in a number of different diseases, and the role of chronic inflammation actually in pain. And we've learned about inflammation, in particular of glial cells, especially in the brain, and the role that those play in chronic pain. But I think some of the things that we're pulling together from that and from other types of studies are that chronic stress, chronic pain states also induce inflammation. So I think the thing that is not necessarily proven per se, but you can tie together from that is that when you have chronic stress and you have chronic pain, you have inflammation. When you have inflammation, you have pain. And when you can reduce some of these things, you probably reduce inflammation and pain. And I think probably, some of these more brain-based techniques, I bet not only help for pain, I bet they will help with other health conditions and will sort of change the way healthcare looks, not just from a pain perspective. People, I would imagine, are going to be healthier in other ways too when they can do some of these things and sort of turn their central nervous system down so they're not always in a fight or flight inflamed type mode.
Yeah, I really like that. It's something we talk about a lot with the people we work with, whether it's with you or under other physicians, is this relationship between our brain circuitry and our biochemistry across our body. So whether it's glial cells or other inflammatory markers, brain gut pieces, but that I think we really, really are coming to understand that this is the supercomputer, and the supercomputer actually runs all the systems, like the physical ones and the emotional ones. And you can use that, computer dial, whatever you want your metaphor to be, to adjust not all kinds of systems that we might not have thought we would have the power over before. That sounded like some hokey thing. Yeah, Yoni.
Yeah.
I just really agree with that. And jumping on this inflammation theme, there was it's in the finding in the past 3 years that blew me away, which they found that this is a group from the University of Haifa, found that the brain creates these memories of inflammation, and if you activate those memories in the insula, it then drives an inflammatory state in the body. So there's, just like you're saying, Abigail, there are these integrated loops, and actually certain patterns of brain activity then can create that inflammation in the body, which is like, whoa, we're only starting to understand the power of those descending projections to the body and the changes.
Yeah. And I think along with that, I think this doesn't have to be a talk about AI, even though everything else is a talk about AI. But I think some of the things we're learning from AI and ChatGPT are that our understanding of consciousness may not be exactly correct. And what is consciousness, and what is our brain doing, and what memories is it bringing up, and what is it doing with those memories when we dream? And, that may also help our understanding of what exactly happens. Like, how does your brain bringing up a sort of memory of inflammation induce inflammation, and what does that say about memories of chronic pain and previous pain? What do we do with those memories, and does how we process them sort of influence our future states?
If we're talking about some of these kind of bigger picture trends, I'll just add the one that I find the most interesting, but I would love your guys's thoughts on it too, is kind of thinking not just within a specific individual, but also in kind of an epigenetic, cross-generational, because we know that chronic pain can run in families. But I think there's really, really interesting research, and we see and talk about this clinically every day at Lynn, about what might be some of the ways in which pain gets transmitted across generations. I'm curious if either of you guys have things that come to mind there.
I mean, I think it's not something I can speak about scientifically, but I think that, um, pain is very much a state of the brain, right? It's created in your brain, and it's real pain. It's created in your brain, and some of the other things that transfer trauma, mental illness. I mean, there's no reason to think that pain experiences don't transfer. We do know, for example, in terms of like stress, especially stress on pregnant mothers, that there are epigenetic changes and changes in the offspring. So, I mean, pain is a stress. So to say that that transfers, I think, is a natural conclusion, but something that would be really interesting to study, because it might sort of provide an insight into how you treat someone with chronic pain who has a family history of chronic pain.
100%. I think it's a little bit on my mind, and then Yoni, you'll go next, because I just got off a kind of a follow-up interview with one of our patients, who is a mom with chronic pain, with a 10-year-old daughter with emerging chronic pain, with a mother with chronic pain. And she said it was so interesting for her, as she learned all of these new ways of responding differently and training new neural circuits, and got her pain to settle down. Her daughter has not had stomach aches, which is sort of the first presentation she was having of emerging chronic pain, primary pain, since her mom learned all of this stuff, because it's kind of become a part of the way they talk together. It was very profound for me to kind of hear, wow, no matter whether it was genetic or whether it was something else, we can break that chain, like the power of neuroplasticity to make new patterns and then to transmit those new patterns. I found incredibly inspiring. Yeah, Yoni, what were you going to say?
That's beautiful. It's a beautiful
Really
story. We do know that chronic pain is heritable. You can look at this like you take twins who are separated at birth and raised separately, and they will tend to either both get chronic pain or neither get chronic pain. The way you estimate that is basically it comes out to 50% heritable, meaning about half of whether you get chronic pain is due to your genes. And when we look at what those genes are, like what do those genes relate to? Well, some of those genes relate to like musculoskeletal processes and bone formation, but a big chunk of those genes are actually related to neurotransmitters and brain function. And so that's part of what's getting passed down, is that the brain's susceptibility to developing a chronic pain state. And then there's a level of trauma that gets passed down, and the parenting, and kind of like high stress parenting that will interact with a kid who's already susceptible to anxiety and create these anxiety states. So there's a lot there. And adverse childhood experiences, we know, create chronic pain, and positive childhood experiences can buffer against that as well. So helping our kids be happy and confident is really important for preventing chronic pain.
And I think what's interesting about that is I think that's we've known things like that for a while, in the sense that a better childhood is a better adulthood. But I think in the past we kind of thought it was, oh, they were raised a certain way, they have anxiety, and they're expressing chronic pain because they're really anxious. They don't really have pain, they're just anxious. But I think now we know more about that. It's not just the mental health issues that you develop from certain experiences. It may actually be discrete pain issues that are separate and therefore need to be treated and not blamed on mental illness.
For sure. And I think I phrase it a slightly different way, but a similar thought is that I think on the things we understand much, much more clearly today, is that chronic pain and emotions do have some shared brain space, to put it not very medically, but they're unique conditions. And so to really understand chronic pain is real, even if it's brain originated. Anxiety is also real, even if it's brain originated. Depression is also real. Addiction is also real. And that all of these really properly belong in the same diagnostic bucket. And I think for me, if I was going to say the most exciting thing from the last 5 years is the WHO coming in with ICD-11 and saying, no, we know this, chronic primary pain, but someday will show up at an EHR near you in ICD-11 as a top level new rethink about what pain is that reflects our understanding that pain is at its core always a process that's mediated by the brain, which is incredible because it gives us this toolbox that we didn't have before. So with that, let me kind of forward look. Let's switch the other direction for a minute and think about first, maybe Yoni, we can start with you on a research front. What are some things we can look forward to in the next year or so coming out of your lab? Studies that you think are particularly exciting that are going to inform the way we treat and understand chronic pain?
Yeah, so about a year and a half ago or so, we published a trial on pain reprocessing therapy. This came out in JAMA Psychiatry for any interested listeners who want to look it up, and showing some really encouraging, remarkable results that 2/3 of people who completed this pain reprocessing therapy program were pain-free or nearly so after treatment. And so one big project we have going on right now is attempting to basically replicate that study and address some of the weaknesses at the same time. But is this really robust? Can this happen? Can we really get people out of pain? Because in the world of science, you show something once, that's nice, but you really want to be able to reproduce it under slightly different conditions, slightly different patients, slightly different clinicians to really be confident. So we are currently about 2/3 of the way through recruitment. So hopefully in 2024, we'll have some results on that.
Tell us a little bit more about the structure of that study.
3-armed randomized controlled trial comparing PRT to CBT to a usual care arm.
And will you explain what PRT and CBT are and what's the...
The PRT and CBT, so they're both psychological treatments. In this study, they are 9-session treatments. Each session is 45, 50 minutes. And CBT is evidence-based, safe, effective, been around for decades and known to be helpful for chronic pain. Unfortunately, not that helpful.
Right, a little helpful.
So a lot of us are looking for something better. I don't want to knock on CBT, but it's safe, it works, just not that well. And I think the easiest way to summarize what CBT is, it's pain management. So learning how to pace your activities so you don't get a pain flare, or how to think a little bit less, more balanced about your pain to try to make it less bad. Pain reprocessing therapy, or PRT, comes from a different angle. It's really aiming for pain recovery. It understands that for a substantial portion of people, the pain is generated by the brain, and therefore the brain can also unlearn it. And we're trying to get people out of pain. And so it has a different goal, has a different understanding of chronic pain, and in our initial work, it has a lot better results than CBT. So, and so we're doing a head-to-head comparison, which is really needed in the field. And if it works, it'd be very exciting, because almost every study to date has shown that different psychological treatments are pretty similar, have very similar outcomes. But we think PRT is going to be better because it actually has a very different set of fundamental premises and understanding of what chronic pain is at its essence.
Yeah, we talk about that a lot with patients and with providers about that while on the surface, they're both talk therapies and they're both involve things that look like mindfulness or reflection, yes, or process, thinking through what's happening and how you're responding, the target is really different. And so in a cognitive behavioral therapy, the target is coping.
Yeah.
And in a pain reprocessing approach, the target is reducing the connection between what primes the brain to turn on pain, which is some kind of a sense of danger or fear, and that pain experience itself. So we're trying to rewire. We're trying to take the mouse who's been pushing the lever in our neural circuits,
Yes.
do more pain, more pain, more pain, and we're trying to kind of extinct that response so that the pain, the brain turns the pain off.
Yeah, that's exactly right.
So Allie, what about clinically? When you think next year, what are some things you're hoping to see in your office clinically that, a year and a half ago, kind of before you had this whole program in place, you would have thought you would never going to get to see in your office?
I think it's still, so patients have been really, really receptive to this therapy. And I think most patients honestly are receptive to it when it's explained properly. And then explained properly, I would say honestly, in some ways differentiating it from cognitive behavioral therapy, CBT, and other types of psychology, because many patients they have a therapist, they have a psychiatrist, they've done CBT. They don't want to do that. They don't want to cope. They don't need help coping. Some of them actually cope quite well. So I think there's been a lot of buy-in. I think educating other doctors, especially outside of primary care, is going to be the next real step in getting buy-in. And I try to do it when I run into people in the hallway, when I run into people in the OR, and they'll tell me about this patient they have that's really, really difficult. They can't find anything wrong on any of the imaging, but the pain's really disabling. I'll say, there's actually there are some things you can do about that. And they seem really surprised most of the time. So I think really getting buy-in from specialists will be one of the next step. And we talk about it when we go to meetings. We talk about it person to person. We send doctors, updates like, hey, this patient's doing so well. They did this, just so you're aware. You might have other patients. But it's going to take time, and it's going to take studies being published that we can actually give them that will, quote unquote, prove to them that this is real. Because I think just like it's hard sometimes for patients to wrap their head around this, that it's not coping, it's actually recovery. It's hard for other healthcare practitioners to wrap their head around it. So I think that's going to be the next kind of breakthrough clinically is getting everyone on the same page.
Allie, if you have a neurologist in front of you and you're going to explain why they absolutely need to have this as part of their practice, what would you tell them?
So, I mean, I would, it's two kind of pronged approach. I mean, one, we talk about do no harm, right? And there's a lot of things that we do, even, medications, gabapentin, we actually do a lot of harm. People fall, people have mood changes. There's really no harm associated with this. So if nothing else, you're providing a service to your patient that can be covered by insurance that is not going to harm them. Okay. So it's at worst neutral. And then the other thing I would say to them is that actually we've seen in a lot of patients, including things that neurologists might see, like back pain, atypical facial pain, neuropathic pain, that people do get a lot better, and they're less bothered by their symptoms because their symptoms are less present. So it's not just that they're coping. To summarize that, it's kind of, why not provide this? Because a lot of the things that you're doing, and I think you can tell the neurologist, is the gabapentin helping most of your patients? Is, the Botox helps some people, it eventually stops working. Do your migraine patients have a lot of other headaches? Yes, they do. So what are you doing about any of these things, and what other tools do you have that would be better than that? They don't. There is nothing.
I love that. Yes. So, all right, Yoni, I'm going to ask you another one on the same theme. I'm thinking about some publications also that came out thinking about kind of this cluster of symptoms that go with primary pain, that it's not just lower back pain or, what we think of as pain, but it also includes things like chronic fatigue and dizziness and gastro. So I'm curious, from Yoni's perspective, if you're sitting at lunch next to the gastro crew at CU Anschutz, where Yoni practices, what does that conversation sound like when you're talking to a gastroenterologist about why they might consider, even though they don't think of themselves as treating pain? I think often.
Yeah, that it's about the brain gut axis, and we know that, you know, there's a lot there. You know, most of the time in people without bowel syndrome, digestion happens automatically, but the brain has all these. We've all felt it, you know, after you, I don't know, you get nervous and your stomach starts to have butterflies. Well, you know, how's that happening? Well, your brain's sending I'm nervous signals down to your stomach, and your stomach's starting to go. "Arr." And that's not just in your head; that's happening in your stomach. And then you might even have to go to the bathroom, and you know, because those changes are really happening, and that the brain has a lot of control. And you know, do your testing, rule out any inflammatory conditions, but then it's you know, it's probably the brain gut access, and that we can work on calming that pathway and helping the brain get, you know, regular safe input down to the bowels.
Yeah. And even truthfully, I think we're seeing, even in cases where there are inflammatory conditions or where there are, you know, things that we would say are truly structural. One of the things our team has learned, I would say, over the past year is we just continue to be surprised when we say, you know, we don't know if we can help you, but we understand you don't have you're at your end of the line on everything. Like, come work with our coaches. Let's see what we can do. And, you know, not everyone every time, but far more times and places than we ever thought were possible. We're seeing the brain's ability to kind of use some conscious reprogramming to settle down all kinds of things that we didn't think were fixable. And I think chronic fatigue and POTS, like, for us, have been lately some of the really, really exciting ones to see that, along with migraine, IBS, are really responsive to these techniques as well. Here's my last question. If you both had a magic wand that you could wave and every physician in the country would magically either know something or do something different in 2024, what would it be?
You want me to go first?
Let's let Yoni go
Yeah.
first.
Right.
Okay.
I'll start with an anecdote. So we just enrolled a patient for our clinical trial yesterday to do this, you know, get randomized to PRT or CBT. And then the patient calls us up and says, I'm sorry, I have to withdraw from your trial. My doctor told me I can't sit for an hour and do therapy. It's bad for my back. And we're like, oh, come on. You need to be like, who is this doctor? And what are they doing? What kind of like awful messages are you giving these patients?
Can you explain why that's such an awful message? Just
Well, it's
clearly.
awful because unless this patient has some kind of very rare condition, it's unlikely that sitting is actually dangerous or harmful for their back.
Right.
And it shows like a lack of flexibility of like, well, you could also just like get up and walk around or take a break or lie on the floor. And I mean, this message of giving a patient, you can't sit for an hour, like, how are they gonna, you know, if they have an office job, if they want to go to a restaurant, like, it's just a very terrifying message to give someone, which is probably unjustified. We don't have a full workup on this person, but we can be pretty confident it's like an unjustified.
I mean, we know
That's-
in 98% of cases from
Yeah.
prior research, it's not
Like
justified.
what? It's hard to imagine, you know, almost. Yeah, what's going to be so? What's going to be damaging to the back after this? So if I had my magic wand, it would be to, you know, the first thing is stop scaring your patients. This is what I want to say. I'll stop there. Like, you know, stop scaring people. And we have these studies showing that when people are given scary interpretations of the MRIs, they have worse outcomes when they're given, you know, benign or more accurate interpretations of the MRIs. Like, yeah, you have a little thing here or there, but tons of people have it. Don't worry about it. Whereas like you have degenerating discs at L4, L5, and then like so my message would be let's scare our patients less.
And instead of scaring them, what's the message you want everybody telling them?
You want to be assessing for indications of, you know, the brain playing a role, the brain's, you know, driving symptoms, and then send them to great programs like Lynn and other awesome brain
Great news.
programs.
That's great news that
Yeah.
if there's even a teeny little of an indication that I mean, there's always an indication that your brain is involved, right? Because all pain has a brain component, that there is a way out. I think that hopefulness in the messaging across the board is amazing. Whether it's, hey, yeah, look at your scan. Congratulations. You are a healthy, normal 72-year-old that has all kinds of things that show up on a scan. And I also have wrinkles and freckles and, whatever. That's the way we look at various ages in our life. And congratulations, the kind of pain you have has a very, very high odds of being able to turn down if you show up and, work with a coach and learn some new tools, which might actually turn out to be fun along the way. In fact, along the way. All right, how about for you, Allie? What are you going to wave your wand and have every
I have to say it's also fear, and that's why I smiled when you said that. So this is a topic that both really drives me and really upsets me, and I call it like imaging fear mongering. So when I get patients, I had 3 patients today who I said like, oh, you have back pain. Tell me about your back pain. Where do you feel it? What does it feel like? And the response is literally, I have an L4 and L5 disc. I have arthritis. And I said, that's not a feeling. That's not what your back pain feels like. That has not, but clearly someone has told them. And then the next thing is, well, my primary care, my surgeon, my whatever told me that my MRI looks really bad. I mean, I've had people literally come crying because of their MRI, and this needs to stop. There is very little that you can see on an MRI that should cause anyone to cry. And this is how people end up having surgery that they don't need. This is how people end up on medications they don't need. This is how people end up with an epidural abscess because they've had an injection they didn't need. There are plenty of interventional treatments that are valid. There are plenty of surgeries that are valid. But we need to stop driving our clinical practice by imaging. And I really think that it comes down to physicians and other healthcare providers, because I think what happens is that they have a patient, they're in a lot of pain, and they feel that they must give them something that is concurrent with their 10 out of 10 pain. And so they read the MRI report, they're not even looking at the MRI, and they make it into this big thing, and they have no idea what they're talking about. So they're like, oh yeah, you got a big L5 disc bulge, like that's causing your back pain, except for the fact that disc bulges don't cause back pain. So I mean, that to me tells me that these people have no idea what they're talking about. And just like when I read a CAT scan, patients ask me to look at their CAT scan, I say, I don't know how to read a CAT scan. I can read you what it says. I have no idea what these things mean. I'm not going to make any assumptions based on this CAT scan. I will give you a printout if you want to take it to a doctor who can help you. So if I could wave a wand, it would be that we stop relying so much on imaging, we stop scaring patients about their imaging, and that we're honest about what we know and don't know, because patients are completely fine, it turns out, if you say, I don't know, but I'll send you to someone who knows, but I can't give you an answer. It does a lot of damage when you try to make yourself look intelligent at the sort of behest of the patient.
Yeah, I love that. And so I'll add too, just one of the very fun things for me has been getting to watch a little bit over the year and a half that, we've been practicing together. How I think you always were thinking along these lines, but the level of confidence and clarity, as you've seen, like, wait, actually, that terrible thing does not correlate with pain forever, and it's not causal of it, because I can see the pain goes away for so many people.
Yeah. I've had a patient
Right.
avoid surgery. I mean, it was a person I had thought about Lynn Health for, but honestly, I mean, this is kind of sad. This was someone who came to me with a plan for a 3-level spinal fusion, who did a couple of weeks of physical therapy and is fine. I mean, it's truly horrifying, but it's also reassuring to know that some simple things work, but we need to do a better job of getting patients these simple things.
And that is what I wish with my magic wand, is that we really do what I wish we'd done instead of opioids, and instead of many surgical and other interventional techniques, which again, I'm not saying that there's not a time and a place for that and for opioids, but the time and the place isn't the front line. And so I think at Lynn, our passion for 2024 is to bring in a new frontline approach to pain, a new frontline approach that says, try, to your point, Allie, try the things that are simple and safe and proven, thanks to Yoni, your research, to work before we try anything else. And let's be frank and straightforward and hopeful with our patients that this is the right approach, maybe even before we even go for that scan. So here's hoping that when we're doing this again and looking at 2025, we're talking about all kinds of other things, because every physician and nurse practitioner and medical assistant and healthcare provider across America has learned these lessons. Although I think we may still be talking about them well into 2025, but let's at least hope that this is the beginning of the revolution.
Oh man, I'd love to also follow up on something Ali said that I think, I would like to hear more about, listeners too. You said disc bulges don't cause back pain. Can you say just a little more about that?
Yeah. So let me try to make this quick. So to cause pain, something needs some characteristics. It needs to have innervations, or needs to have nerves that go to it. It needs to be capable of sustaining an injury, like a fracture or something like that, that could cause those nerves to get irritated and cause pain. And the pain needs to be reproducible in like a healthy volunteer. So, muscles can cause pain. Certain parts of the bone, like the periosteum, the outside of the bone, can cause pain. Nerves can cause pain. Discs can cause pain. Generally, the pain that discs cause are because their relationship to other objects near them, like the nerve roots. Discs can bulge, and other structures in the spinal canal can cause stenosis, narrowing, and that can cause weakness in the legs, can cause numbness in the legs, heaviness in the leg. And a lot of those people have back pain. But what we see is that when we treat the discs, when we fuse people for disc issues, their back pain doesn't get better. Their leg pain gets better. So disc pathology, often like a little bit of a bulging disc, is not the reason you have back pain. There's no mechanism to explain why a little bit of a bulge of a disc that's maybe touching a nerve root, touching another structure in the back, could actually scientifically cause back pain. I think what gets confusing is that a lot of people with spinal narrowing, with stenosis, with degenerative arthritis, all have disc bulges. So people will blame the disc bulges, but when you fix those disc bulges, it's pretty rare that the back pain gets better. There are exceptions, but it's not. There's no one-to-one correlation between a little disc bulge and back pain.
And maybe they get better for the reason that in Yoni's studies, some people that got a placebo saline injection that they were told was a placebo saline injection also got better.
Yeah.
Correct. And we see that with pain injections. The placebo effect's very strong. And it's good. It's fine. We accept it. We like it. It's great. But I think the thing you have to be careful with is when you're doing injections as a surgical precursor, you have to be very, very careful what you're injecting and exactly where, because you don't want that driving surgery.
Yoni, if you were going to give anybody listening to this that has a bulging disc a better question to ask themselves than what is on the MRI, 1, 2, 3 questions that people could use to start thinking in this new frontline way of thinking about pain.
The question would be, are there any inconsistencies in how your pain behaves? And what I mean by that is things that don't really make a ton of sense when you step back and think about it. Like, for example, these are all real life examples from patients or people I know. My back hurts when I stand still, but it doesn't hurt when I run for 6 miles. Interesting. Let's think about that. Like, what could cause that? Is it plausible there's something in the back or the spine? Not so much. You think 6 miles of pounding would make it hurt. Or my back hurts when I walk on concrete, but not when I walk on wood. Interesting. Does that make a lot of sense from a biomechanical perspective? Not really. It's a very similar experience. So look for these little clues that would let you know that the brain is probably playing a role. So that's a question.
I think that's good. I think the exercise thing in particular is interesting. I mean, there's like the rare back pain disorder that gets better with exercise, but it's not the majority of people. So if pain is getting better with exercise, I mean, yes, sometimes people with arthritis will feel a little bit better, but there's clearly a distraction, or you're doing something else. There's a brain part of that. So what if you could replicate like doing exercise for the rest of the day in the brain? Maybe you wouldn't have something that you really need to bring to a doctor. Maybe you just live with it because it doesn't bother you that much anymore. It's a minor thing.
That is what we do. That's the fun of this approach. You guys,
Okay.
yeah, go ahead, Yoni. What were you going to
Question
say?
to ask yourself would be, do I have a history of multiple different conditions that kind of fit in the same family? Like, oh, actually, I did have tummy aches when I was a kid, and right, and those headaches I had in college, and now my back hurts. Like, connect those dots. Oh, I've had a dizziness thing, or loud sounds tend to really bother me. All these, I'm tired a lot. I feel tired. So connect all those dots and see, how do you explain having all those different dots? Like, oh, like the brain is often a pretty compelling explanation. That's what connects the dots.
This is my wish for when I wave my wand. It's going to be the same way we as a medical community have learned to screen for alcohol use. We've all gotten over the hump and are screening for depression or anxiety. I mean, I know because I was in offices as people were first being asked to screen for depression. It felt overwhelmingly like one more thing that we couldn't possibly do. I really hope we're all screening for multiple pain-related symptoms using like a PHQ-15, a somatic symptoms screen, because it leaps off the page when you ask people about multiple symptoms.
Exactly.
All right, one more question, and then let's call it a wrap. those two, you'll catch all your patients with pain, that's for sure, or a lot of them. You guys, first, thank you. Second, I hope someday you two get to meet in person. It will be fun. A fun occurrence at that point. And as always, just really, appreciate both of your guys's everything you're doing for patients every day, but also your help. And as we at Lynn are finding ways that we can do our piece to make this more and more available in a way that insurance can pay for, in a way that works in the flow of a physician's office. Physicians, nurse practitioners, providers office, is really, really exciting. And I think 2024 is just going to show more and more and more of this happening out there.
Thanks so much for having me and us, Abigail. It's been a pleasure. Thank you for all the work you and the team at Lynn are doing to get this out there and make it available. So it's a pleasure.
Yeah, and thanks for having me. Thanks, Abigail, and thanks, Yoni, for doing the research that I think helps insurance companies also get over it's a necessary evil to involve them. So when there's research, they usually accept things better. So
agreed.
Big help in many different ways.
Good.
All right, you guys.
Thank you.
Talk soon.
Bye.
Talk soon.
Bye.
Bye.